my colleagues already did a great job discussing how to classify and different techniques to treat recurrent varicose veins today. And I think we need to be creative and adapt to the patient anatomy and not the other way around. So I'll present some cases with foam, but I usually try to combine different techniques so I can adapt to the patient anatomy. I have nothing important to disclose, and the patient that I believe are best suited for foam are these type of patients with very complex and very tortuous anatomy. For example, this type of saphenofemoral junction recurrence on this type of saphenopopliteal junction recurrence, especially when we have this type of scar tissue surrounding that will make redo surgery very complex, as you mentioned. And I know some colleagues like to do thermoablation with multiple introducers, but I personally like to do that with foam. I think it's simple and also very effective. The same thing applies when we have this type of recanalization of the saphenous compartment. If it's a straight segment, I would rather do it with laser or on other thermal techniques. But if this type of anatomy, very tortuous, multiple channels, I think foam is the best treatment to this type of patients because foam flows and fills every possible space so we can reduce the second recurrence. In terms of perforators, yeah, we can argue that on the, sorry. We can argue that this one here is pretty straight, is a thermal perforator. It's very good for laser. I personally treat those with foam as well, but I can accept that some people like to do with laser. But for example, this one, it's not very tortuous, but it's an infrapatellar perforator near the fibula head. There are some nerves nearby here, so I rather not use thermal techniques in this region, and I usually treat my patients with recurrent perforators with foam. When I have a superficial recurrent varicose veins, non-truncular varicose veins, redo phlebectomy is a very good option, but if the skin is damaged, if fibrotic skin or scar tissue, I prefer to do it with foam. And the same thing applies when I have this type of patients with advanced skin changes, very fibrotic skin, that thermoablation will have a higher risk of skin or nerve burn, and redo phlebectomy will be very challenging. So how do I do it? I'll try to keep, I think my colleagues already explained very well the evidence and the studies, so I'll present a more practical approach. How do I do it? I try to keep my setup pretty. I use longitudinal view, direct injection, small syringes. I use polydacanol in different concentration depending on the patient characteristics, of the characteristics.